Hi, this is Tammy McClish. Let's take a look at radiographic skull and sinus positioning. Now, when you receive a requisition for a skull of sinuses, you need to take a look at the requisition to see what part of this anatomy you're going to need to x-ray. Typically, you will be x-raying the entire skull, or just the facial bones, or just the sinuses. When we're looking at the skull is part of the axial skeleton. It is at the superior end of the vertebral column, and the skull is actually the thickest bone in the body. There are 22 bones in the skull. The top of the skull is called the vertex, and the bottom of the skull is called the base. Now, when we're looking at the facial bones, there are 14 bones of the facial bones. And the reason that we have the facial bones is to protect our upper respiratory system and a little bit of portion of our digestive tract that is located in the face. When we're looking at the sinuses, we're looking at chambers, and these chambers are there in order to give our voice resonance, and they also allow us to have a skull that is very light so that it is not very heavy resting on top of our cervical spine. The sinus cavities that you're going to see are the frontal sinuses, the ethmoid and sphenoid sinuses, and the maxillary sinuses. Now, even though when you look at this particular picture, you're seeing all of them in front, you will also need to take an x-ray with the patient turned to the side. Here is a typical digital radiographic room. Now, when you are x-raying the cranium, because the cranium is located in the axial skeleton, you're going to have to utilize a KVP that is going to be in the upper range. If you are going to be using an analog system such as film screen, you're going to want to use about 65 to 85 kVp. But once we get into the digital, we need to be about 75 to 90 kVp. The focal spot size should be small, and the reason we want a small focal spot size is because we want to allow for the potential for detail in our radiographic images. We want to make sure that our exposure time is very short and that the milliamps per second that we select is adequate for sufficient density. You will find that people that have African American descent will have thicker craniums compared to people that are Caucasian. So you will find that you probably are going to have to use a little bit more MAS in those particular situations. The source to image distance is going to be 40 inches. Now you can take these particular images on the radiographic table utilizing the bucky, or you can take them at the upright chamber utilizing the upright bucky. Personally, I feel that it is much easier to position a patient at the upright bucky. It's going to be more comfortable for the patient, and it will also allow us to project air fluid levels. That's going to be extremely important when we get to the sinus modules. But right now, if you have a trauma patient, you probably want to put the patient on the table. But if the patient can sit in a chair, then go ahead and utilize the upright bucky. The reason we are using a bucky is because we are x-raying something that is bigger than 10 centimeters in size. Remember, a knee is about 10 centimeters, so anytime we x-ray anything bigger than a knee, we are going to have to use a bucky. And that's because we're going to have a grid inside of that bucky. So once we select a grid, we're going to need to make sure that our KVP is over 70 KVP whenever we're using a grid. Now, when you're using any digital cassette, please always try to make sure that you are centering to the very center of the image receptor and use close collimation. Digital is very non-forgiving. It likes to have the center ray in the very center of the IR. Make sure you shield the radio sensitive areas. If you can, you could also give the patient a thyroid shield, but please make certain that you are not going to put that so close to the cranium that you cannot see the cranium. When you are taking these x-rays, you want to tell the patient just to stop breathing, and that's suspended respiration. Now, this is probably the most important portion of the lecture, is the topographical landmarks. These are going to be very important for you when you're positioning the patient. So when I'm talking about these, you may want to touch that part of your face so that you can see where that is located. I'm actually going to go to the bottom diagram first. So the glabella is going to be just above the nose. That is the positioning point, the glabella. If you come down just below the glabella, there is a little portion that is called the nasion. And the nasion we're going to be using quite a bit also. If you come down below the nose, that is called the acanthion. If you come down to the mandible and the chin, that is called the mental point. If you take your finger and move it over to the side of your face, that is an angle called the gonion, and that is located on the mandible. And then we also have some lines here. Just above, you see the interpupillary line, the IPL, that goes between the pupils. Above that, you see an arch, and that's called the supraciliary ridge arch. And ciliary are little bodies of muscles that are located in the eyes. And then above that, you have the supraorbital groove. Now I'm going to go up to the very top portion. I'm going to start with EAM, the external auditory meatus. That is the hole in your ear where that we have sound coming into our ear, and that is the EAM. We use that quite a bit. From there, we jump out to the different lines. The first line you're seeing is line A, which is the glabellomeatal line. B is the orbital meatal line. C is the infraorbital meatal line. D is the acanthomeatal line. E is the lips meatal line. And F is the mentomeatal line. So we're going to be using quite a few of these when we're doing our positioning. Okay, so typically if you're going to have a patient in for a skull x-ray, you are going to be taking 4 views. The 4 views we're going to be taking are the PA, the town, and both laterals. Now, back about 20 years ago, we were x-raying a lot of patients' skulls. We tend not to x-ray the skull that much anymore, and it's because of the fact that we have CAT scan now. So more often, we are going to have the patients going through a CAT scan for skull x-rays. But if you would have to x-ray a patient for a skull, it is going to be easiest to put the patient on the skull PA, and it's actually going to provide you with a better image because the front of the face is going to be closest to the image receptor. But if you can't, go ahead and put the patient on the back. So for a PA, we're going to put the patient prone or seated erect. We're going to position the part with the head resting on the forehead and nose. So I tell the patient, go ahead and put your forehead and nose up against the x-ray chamber. And once I have them positioned, I'm going to make sure that the mid-sagittal plane is perpendicular to the midline of the image receptor. The orbital meatal line is perpendicular to the IR. Then I'm going to take my central ray. I'm going to make sure it's perpendicular to my IR, and I'm going to bring it up so that it's going to exit out the glabella. So I'm going to put one finger on the upright bucky, and it's going to be at the glabella, which is just above the nose, and I want to make sure that's where my central ray is coming in. Once I have that, I'm going to tell my patient, I'm going to move the image receptor in front of your face, and I'm going to align my upright bucky with my x-ray tube. Now that is for a PA skull view. Sometimes we're going to have the patients coming in and we're going to be doing a 15-degree PA axial. If we're going to do this, then we're going to direct the central ray caudad. Caudad and caudal are the same term. That would mean that the x-ray tube is going to be pointed down toward the patient's feet. With that central ray coming in, I want to make sure that I'm directing that 15-degree caudal angle to the orbital meatal line, and it is also coming out the nasion. Now the first x-ray you're seeing is the one with a 0-degree tube angle, no tube angle whatsoever. And the second x-ray you're seeing with a 15-degree caudal. The difference is when you're using that 15-degree caudal or that axial view, you can see the orbits. And these orbits are going to be higher on the cranium than with the 0-degree angle. For both of these x-rays, I'm going to have the patient hold their breath. I probably won't tell them to take in a big breath and hold it. I will just say stop breathing, because if they're breathed, then they'll go ahead and move. I'm not worried about air coming in, coming out. I'm just making sure that they're not moving. So when I'm looking at my pictures, let's look at that first x-ray with just the PA with the 0-degree angulation. For the frontal bone, I'm going to see the frontal bone and the cystigale are demonstrated without distortion. The petrous ridges are at a level superior of the superior orbital margin. There's no rotation. There's equal distance between the orbits and the lateral skull. Now when I take a look at my 15-degree PA axial, we are seeing that the greater or lesser wings of the sphenoid, the frontal bone, and the superior orbital fissures are in this particular position. The petrous ridges are projected in the lower 1/3 of the orbits. There's also no rotation. There's equal distance between the orbits and the lateral skull. You want to make sure you have optical density and contrast to visualize the frontal bone and the surrounding structures. You want to have sharp, bony margins with no motion. So my second view, I'm going to have the patient turn onto their back, and this is going to be a PA 30-degree axial called a town view. The patient could be seated or they could be supine. I'm going to make sure that I'm positioning the part with the mid-sagittal plane aligned to the central ray and the midline of the table and or the IR, and the IR is perpendicular. I have no rotation or tilt. I'm going to depress the chin to bring the orbital meatal line or the infraorbital meatal line perpendicular to the IR. And then I'm going to center the IR to the CR. The central ray is going to be directed through the foramen magnum with a caudal angle of 30 degrees to the orbital meatal line or 37 degrees to the infraorbital meatal line. So the central ray is directed to approximately 2.5 inches above the glabella, and the glabella is going to be above the nose. And you're going to want to make sure the patient has stopped breathing. Now, when we used to x-ray the patients for this particular position, we would actually center at the hairline. Sometimes I feel that's a little high, depending upon a patient's hairline. So this is one that you're just going to have to make sure you're about 2.5 inches above the glabella and you should be fine. When we're looking at our x-ray, we can see the occipital bone, petrous pyramids, and foramen magnum. The dorsum sellae is within the foramen magnum. There's no rotation evident by symmetry of the petrous portion. Pyramids of the temporal bone. Optical density and contrast to visualize the occipital bone and structures within the foramen magnum. And we have sharp, bony margins with no motion. Our third and fourth image will be our lateral skull. Now it's easiest if you have the patient lie on their stomach or they are going to be prone. They could be seated or they can be on the table. If you're going to take the right lateral first, you want to have the right arm by the side, left hand up. The head is going to be in a true lateral. The mid-sagittal plane is going to be parallel to the IR, and the interpupillary line is going to be perpendicular to the IR. You're going to adjust the chin to place the infraorbital meatal line parallel to the upper and lower IR edges. The central ray is going to be 2 inches superior to the external auditory meatus. Once again, you're going to want to make sure that you suspend respiration for this exposure. When you're looking at the x-ray, you want to make sure that the entire cranium is visualized, and you want to superimpose the cranial halves. The entire sella turcica and dorsum sellae will be in this particular position. There will be no tilt evident by superimposition of the orbital plates or the roofs. No rotation is also evident by superior imposition of the greater rings of the sphenoid and mandibular rami. Optical density or brightness and contrast are going to be adequate to visualize the cellular structures. Sharp bony margins and no motion. After you x-ray the patient for the right lateral, you're going to bring the patient's left arm down, right hand up, turn and put their left ear up against the table, and you're going to position the patient for the opposite lateral. Now, if we are going to be x-raying the facial bones, we're not worried about the cranium. We're just worried about the facial bones. So for a PA axial 15-degree caudal method, you're going to have the patient prone or seated erect. The mid-sagittal plane is going to be aligned to the CR and to the midline of the table and or IR. With the forehead and nose resting on the IR, you want to adjust the head to place the orbital meatal line perpendicular to the IR. You're going to direct the center ray 15 degrees caudad or caudal toward the feet to the orbital meatal line exiting at the nasion. So you always want to take your finger, put it on the table at the nasion, and make sure the central ray is at that nasion. Once you have that in place, just line up your X-ray tube with your X-ray cassette or your IR. When you're looking at the X-ray, you want to make sure that your orbital rims, maxilla, nasal septum, and zygomatic arches are within the X-ray collimation. Petrous ridges are projected in the lower 1/3 of the orbits. No rotation. Equal distance between the orbits and lateral skull margins. Optical density or brightness and contrast to visualize the maxillary retention and orbital floor. Sharp bony margins and no motion. So the next view that you would have to create after you position your patient for a Caldwell, you would need to move on to the lateral. Now with the facial bone, it's a little bit different than with the skull. With a skull, you're going to be x-raying both sides, the right and left lateral. For facial bone, you only need to x-ray the side that is affected. So if the right side is affected, you are going to put the right arm down by the side, have the patient put the left hand up and put their right ear up against the table. You can actually have the position patient seated or on the table. Adjust the head to a true lateral with the side of interest closest to the IR. Adjust the mid-sagittal plane parallel to the IR. The intrapupillary line is perpendicular to the IR. Adjust the chin to place the infraorbital meatal line parallel with the top of the bottom of the IR. Your center ray is going to be perpendicular, entering the superior portion of the zygoma, midway between the EAM, which is the external auditory meatus, and the outer canthus. You are going to have the patient stop breathing when they have the exposure. And when you're looking at the image, you want to evaluate to make certain that you have superimposed facial bones, greater wings of the sphenoid and sella turcica. The region from the orbital roofs to the mentum is going to be demonstrated. There is no tilt evident by superimposition of the orbital plates or the roofs. No rotation evident by the superior imposition of the greater wings of the sphenoid and mandibular rami. Optical density, brightness, and contrast to visualize facial structures. And you're going to have sharp, bony margins with no motion. The next view you are going to take of the facial bones would be a parietal acanthial 37-degree Waters view. Once again, the patient could be prone or seated erect. You're going to center and adjust the mid-sagittal plane perpendicular to the image receptor and rest the patient's head on the extended chin. Adjust the orbital meatal line to form a 37-degree angle to the image receptor. And then the central ray is going to be perpendicular exiting the acanthion. Remember that the acanthion is just below the nose. Typically what I do is I put my finger on the table or the upright bucky and I make certain that that's where I'm going to center. When you're evaluating your images, you will have general survey of the facial bones, inferior orbital rims, maxilla, and nasal septum. The petrous ridges are going to be just inferior to the floor of the maxillary sinuses. You will have no rotation, which is evident by equal distance between the orbits and the lateral skull. optical density or brightness and contrast to visualize the maxillary regions and surrounding structures, and you're going to have sharp bony margins with no motion. Now, typically the physician may also ask for a 55-degree waters. This just will be a steep waters compared to the 37-degree waters. Now, if a patient is coming in for a nasal bone X-ray, typically what you will do is you will take the last X-ray, which was the 37-degree waters, and then you're going to take pictures of just the nasal bones. You would want to perform a right and a left lateral. The reason you want to perform the right and the left lateral is because we have two nasal bones side by side, and it's very important that the patient is 100% lateral for these images so that you can see that if there's a fracture on each particular side, or the right nasal versus the left nasal. As you can see in this photo, the patient is going to have their head right up against the IR, so this will be a tabletop exposure. Typically, you're going to select a finger technique, so if you normally take a finger x-ray at maybe 55 kVp, 1.5 MAS, then that's what you will use for each of these pictures. You want to have the patient semi-prone or seating erect. You want to center the nasion to the IR. Please remember the nasion is above the nose. You want to make sure that you adjust the mid-sagittal plane parallel to the IR. You also want to make sure that you adjust the mid-sagittal plane parallel to the IR. The infraorbital line is adjusted parallel with the transverse axis of the IR. The intrapupillary line is perpendicular to the IR. And the central ray is going to be 3/4 of an inch distal to the nasion. Once again, the nasion is going to be located at the top of the nose. When you're looking at these x-rays, remember you're going to take one of the right side, one of the left. You want to make sure that the nasal bones are on the image with soft tissue structures. The frontonasal suture to the anterior nasal spine are going to be on this image. There's going to be no rotation. The complete profile of the nasal bone will be shown on the images. And the frontonasal structure to the anterior nasal spine are going to be within the collimated field. You want to have optical density, brightness, and contrast to visualize the nasal bones and surrounding soft tissue structures. And you want to make sure that you have sharp, bony margins with soft tissue detail and no motion. Now let's move on to our sinus x-rays. The reason they are called paranasal sinuses is because para means around or around the nose. Paranasal sinuses are the sinuses around the nose. The first image you're seeing is where the image receptor is tilted. The second image you're seeing, there is no tilt to the image receptor. If you have a patient that comes in for paranasal sinuses, you will x-ray the patient PA Caldwell, Waters, one lateral, and then there is a other film that you're going to be taking, which is called the submental vertex. So for the PA Caldwell, the patient is always going to be seated erect. You really need to have the patient seated for sinus x-ray so you can see the air fluid levels. The face is going to be touching the IR. You want to adjust the head so that the orbital meatal line is parallel to the IR with no rotation. You want to center the IR to the nasion. The central ray is going to be horizontal or parallel to the floor, and it's going to exit the nasion. Now once again, remember the nasion is going to be at the very top of the nose. When you look at your x-ray, you're going to be able to visual the frontal sinuses and the anterior ethmoid sinuses. The petrous ridges will be in the lower 1/3 of the orbits. No rotation. Equal distance between the orbits and lateral skull. Optical density and brightness and contrast to visualize the paranasal sinuses. And you're going to have sharp, bony margins with soft tissue detail and no motion. For the lateral of the sinuses, you're just going to take one. Typically, we take the left, and the reason that we take the left is because the patient is going to be facing us, and we can actually move the image receptor up and down much easier than having the patient turn the other way. The patient's going to be facing the IR. They're going to turn the head into a true lateral. They're going to raise the chin to bring the infraorbital meatal line perpendicular to the front edge of the image receptor. No rotation. The mid-sagittal plane is going to be parallel, and the intrapupillary line is going to be parallel to the image receptor. The image receptor is going to be centered to the central ray. The central ray is going to be horizontal to midway between the EAM, or the external auditory meatus, and the outer canthus. When you look at the X-ray, you're going to see all the paranasal sinuses are demonstrated. There's no rotation or tilt, superimposition of the greater sphenoid wings, orbital roofs, and sella turcica, optical density or brightness and contrast to visualize the paranasal sinuses, and sharp, bony margins with soft tissue detail and no motion. The third X-ray you're going to take is going to be a Waters, also called a parietal canthiole. This is that 37-degree Waters we talked about a few moments ago. The chin is going to be extended and touching the imaging device. Adjust the head height of the IR to center at the acanthion. Once again, remember the acanthion is going to be below the nose. Adjust the MML, and the MML is the mentomeatal line, perpendicular to the image receptor. The orbital meatal line is 37 degrees to the image receptor. There's no rotation. The mid-sagittal plane is perpendicular to the IR, and the center of the image receptor is to the central ray. The central ray is going to be horizontal and perpendicular to exit at the acanthion. Once again, the acanthion is below the nose. When you look at the image, you're going to have an unobstructed view of the maxillary sinuses. Petrous ridges are going to be just inferior to the floor of the maxillary sinuses. Optical density or brightness and contrast to visualize the paranasal sinuses. Sharp, bony margins with soft tissue detail and no motion. Now, we always save the best for last. This is the last of the paranasal sinus views. This is called the segmentovertical, or the full basal view. Patients have difficulty in achieving this view. Patient is going to be seated. They're going to lean back in a chair and extend the head to rest the top of the head against the image receptor holder. We're going to adjust the head to rest the infraorbital meatal line as near parallel to the plane of the image receptor. We're going to ensure no rotation or tilt, and we're going to center the image receptor to the central ray. Central ray is going to be horizontal and perpendicular to the infraorbital meatal line, centered to the midpoint between the angles of the mandible, and you're going to be at least 1.5 to 2 inches inferior to the mandibular symphysis. We're looking at the X-ray. We have an unobstructed view of the sphenoid, maxillary, and ethmoid sinuses. Mandibular condyles are projected anterior to the petrous bone. There's no rotation or tilt. You have symmetry of the petrous pyramids and equal distance between the mandibular border and lateral sinus. Optimal density and brightness and contrast to visualize the paranasal sinuses. Sharp, bony margins with soft tissue detail and no motion.